Hey, good afternoon, everyone. Thank you for joining us for our annual installment of Medicare Madness. Got Marcia Mantell here for the fifth year in a row, and very happy to have you, Marcia, and looking forward to learning what is changing with Medicare in 2026. So far, I've only heard bad things, so hopefully not everything's bad, but you'll be telling us over the course of the next hour. If anyone has any questions, the clarifying questions, please type those into the chat or the question box. I'll be looking at both of those during Marsha's presentation. If it's another type, any other question, just hold them for the end, and we'll do a Q&A at the end of the presentation. With that, Marcia, turn it over to you, and you can start telling us about what's happening next year with regards to Medicare.
All right. Well, John, thank you so much for inviting me today. Let me just get my slides up. Yeah, John and I did get to chat for a few minutes before we all got on. So thanks everyone for joining us. And yeah, I feel like I'm just the bearer of bad news on a daily basis this year with Medicare. Many things have changed. I have a lot of slides, a lot of examples, and I'm going to go through pretty quickly. So if you do have clarifying questions, I've just got to pull up my slides again. Hang on one second. Um, if you do have questions, please put them in the chat because we don't want to miss them. It's just that I can only look at so many things at one time. All right, let's try again. There we go. All right. I'm going to dive in with what we're going to cover today. So we're going to first look at Medicare basics and changes coming for 2026. Then I'm going to spend some time talking about the even bigger changes in the Part D drug plans for 2026. And my big message here to you all is that you're on your own for your drug plan changes and reshopping your plans. Then we'll look at what's happening in Medicare Part C plans, the Advantage plans, a lot of changes there. Then I've got some practical stuff for you. Actions you can take during OEP, the Open Enrollment Period, which is the time period we're in right now, and then some resources and additional info. So with that, let me just repeat. There really isn't any good news this year. If you're healthy, keep it going. This is all good for you. But there is just so much going on. And just as a level set, if anyone isn't in Medicare yet, I'm super happy you're here because you do need to hear about these kinds of things to prepare yourself for what's coming. Or you may be helping parents or an older friend or a relative or someone. So let me just give you the lay of the land again. We have these two flavors of Medicare. On the left, I call it the quartet, and on the right is the trio. So the quartet is where someone in Medicare has four individual piece parts. They have Medicare Part A, which covers hospitalization stays and inpatient at skilled nursing. They have Medicare Part B, that's what covers your doctors, your outpatient treatments, that sort of thing. They also have a separate piece called a Medigap plan that pays your share of underneath A and B. And then they have a standalone Part D plan. That's the quartet, four individual piece parts. The trio works differently. This is a substitute for Medicare. There's Medicare Part A again and Part B. You still have to have those. You have to apply, enroll, and pay your Part B premiums. But then you assign all of your rights and privileges, if you will, over to an insurance company, and you get the Part C plan. Part C comes wrapped with Part D in most cases. So that's Medicare Advantage. There's some extra coverages, some dental cost sharing or some vision cost sharing, but mostly it's just a completely different structure to how you get your health insurance and your health care coverage in retirement. What we're going to focus on today are the two parts that are only 1-year contracts. So A and B are permanent. Medigap is relatively permanent. Part C is a 1-year contract. Part D is a 1-year contract. That means behind the scenes, anything and everything can change with the insurers, and it does. So you are reshopping at this time of year for your Part D standalone plan and or your Part C with a Part D wrapped in. And we'll cover those details in a bit. The other thing to note is that we are in the middle of OEP, Open Enrollment Period. Now, there are 5 different enrollment periods for Medicare. If you haven't yet gotten into Medicare, you would fall on the left-hand side of the slide, the initial entry into Medicare. We are not talking much about that. But we are talking about the annual reassessment or the annual reshopping your plans. There is only a 7-week period for you to reshop your plans. October 15th, so it started about 2 weeks ago, and it goes until December 7th. And at this time, every year, this annual re-enrollment comes up for you to reshop your plans to see, are you getting the best cost? Are your drugs still covered? Are your doctors still in the Part C network? All kinds of considerations. In addition, at this time of year, though not exactly related to the open enrollment period, we get all of the new Medicare costs for the following year. Now, again, those of you already on Medicare, you'll get your official notice from Social Security at the end of November, probably early December this year. And that determination letter will tell you you have a cost of living increase coming for Social Security payments if you're collecting Social Security. It just announced the other day 2.8% increase in the cost of living for Social Security. In that same letter, they also tell you your Part B premiums and how much you'll be paying based on your incomes. So you'll get a communication later this year. But in the meanwhile, some costs are out and most of them are not. But let me share with you what we know so far. With Part A, again, your hospitalization costs, this is the part of Medicare, you don't pay a monthly premium for this. You only pay usage costs if you use a hospital. If you are in an accident, have a health incident, need to be in the hospital, and then perhaps to skilled nursing. What you see on the slides here are the costs that were issued by CMS. They're not 100% locked in. They were issued in the summer. I think they're final, but we could still have a slight change. In the pink, underneath in the parentheses, like the 1676, that was the Part A deductible. If you went into a hospital as an inpatient, you got charged $1,676. This year, it was announced, though still TBD, $1,716 for next year. So we have an increase. It's a pretty hefty increase. So Part A goes up for the deductible. The day rates, if you end up in the hospital for a long time, is $429 is the day rate if you're in the hospital after 60 days, and then $858. And skilled nursing in the blue side of the box here jumped from $209 to $214. These are annual costs. They do tend to rise every year. And so this is not startling or new or frankly that exciting. What is a little distressing, though, with Part A is funded by our FICA taxes while we're working. It's the HI Trust Fund, the Hospitalization Insurance Trust Fund, that we fund while we're working. When the trustees' report came out in June of this year, they had a big news item that is Part A's trust fund is expected to start running a deficit starting in 2033, which is 3 years earlier than last year's projections. So this is a little alarming, I will say, because no one pays attention to Medicare, to be honest. We are all focused on Social Security, or most of the industry focuses, somewhere else. But this hospitalization insurance piece for folks who are older or those who are disabled Americans who are on Medicare, hospitalization insurance is really important. And if it runs dry, then the trust fund, if it really is bleeding faster than we were hoping, it has to be made up by the federal dollars, tax dollars. So expect to hear more about the trust fund terminating or running dry sooner than expected over the next couple of years. Congress does need to deal with this. we'll see what they do. So that's sort of the alarming part of Part A. The increase in the cost, not alarming. This is the typical trend you'll see every year. But budget accordingly. If you don't have a Medigap plan, or if you're not in a Medicare Advantage plan, you need to pay this out of pocket. So just something to put in your retirement income plan cost and budgets. All right, Part B. Part B, it's still always a sort of a thorn in everybody's side that they have to pay monthly premiums to get a Part B insurance. And this is the Part B step up that you can see every year since 1966. Part B was always a co-pay arrangement. You pay part of the premium, the federal government picks up the other part. 1966, people paid $3. We are all the way up to $185 per person per month in 2025. That's what we know. That's our standard rate this year. What we expect to happen for January is the Part B premiums are going to jump significantly to $206.50. Now, this is out of the trustees report. And again, it is not a final number yet. Could go up, could go down a little. But I know that the trustees have been spot on accurate with what they have put in the trustees reports. And CMS then issues the final numbers later this month, in November. That's an 11.6% increase. This is not a typical increase. 2 years ago, I was using Part B inflation rate of 5% per year. Last year, I thought I was being very, out of the box, going, oh my gosh, I think I have to use 6% inflation. I was never going up to 10 or 11.6% increases, but that looks like it's going to be the Part B premium for 2026, the standard rate. So what that means to you all is you're going to have a big increase in your outlay to $206.50 per month. You can see, in 2024, we were only $174.70 and then $185 last year. You also have this one-time Part B deductible, these first dollars in. We all have to pay the first dollars when we see a doctor or use outpatient services. It's a minor amount. It's an annual amount. But when you're budgeting for the year, you're starting at $2,766. This is literally out of your pocket. Instead of $2,300 just 2 years ago, we're up to almost $2,800. And again, Part B only pays 80% of the cost. So if you don't have a Medigap in place, you would be responsible for the other 20% of services. If you have a Part C plan, a Medicare Advantage plan, the pricing is quite different in how you pay and what you pay. But you still have to pay this Part B premium. For those of you who have higher income, though, you may still be working. One of you is working, let's say in a married couple, one of you is working, one of you is retired and on Medicare, but you have higher income, or you just have lots of awesome investments in your portfolio that are kicking off high interest dividends, or you're drawing from your IRAs and such. It's not hard to have high income in retirement. This chart here is the IRMAA chart for 2025. So if you're married filing jointly and you have income, we call it Medicare MAGI. So this is your AGI from 2 years ago, plus any tax exempt interest. You just add those two numbers together. If you're married filing jointly and that Medicare MAGI is $212,000 or less, that's when you pay the standard $185. If you go $1 over $212, you find yourself meeting IRMAA. If you're a single filer, the number starts at 106. So your Medicare MAGI has to be 106 or less. And married filing separately, you have a different arrangement. You either pay the standard or you pay a very high rate. So the IRMAA in that column to the right, that's sort of orangey color, this is your income related, high income, monthly adjustment amount. Means testing. When you have high income in retirement, you have to pay more for your Part B premiums. You don't just get to pay the 25% share, which is $185 per person per month. You have to pay more. And so in 2025, these are the IRMAA tiers. You see the brackets by income and then the IRMAAs going down the columns. So the highest income earners are making $750,000 a year or more and are married filing jointly, or $500,000 or more as a single filer. They were paying $628, $629. This is what we know. Again, because the Part B premiums have not been issued, nor have the brackets, we're not sure exactly where IRMAA is going to look, what IRMAA is going to look like for 2026. But using the trustees report, again, don't shoot the messenger. I've just laid it out a little differently. So in 2025, that standard premium 185 jumps to 206.50. Well, each of the IRMAA tiers also increases, and they're going up tremendously as well. So if you're in that tier 5, the highest income folks, you were paying $628.90 per person per month. Now you'll jump to $702, we think. So again, subject to change, and the income tiers will move as well. My best guess at this point is single filers will jump from 106,000 to 109,000 in Medicare Maggie, and married filing jointly from 212 to 218. They don't move a lot every year, so it's kind of in that range. But you need to, if you're in an IRMAA tier, you need to really plan and budget for a much bigger payout, premium payment coming right out of your Social Security check, or you're writing a check. And just a quick reminder, if you're entering Medicare in 2026, you can still appeal an IRMAA upcharge if you have one of these 8 reasons. Mainly it's that you have work reduction. If you retired, you can appeal a high IRMAA that's been assessed to you, and you have 60 days to do that after getting your determination letter. All right, that was A and B. Please don't leave yet, because we're not done. Let's talk about Part D plans. This is really what OEP is about, your open enrollment period. It's about making sure, if you have a standalone Part D plan, that you're still getting the best deal going into the new year. And again, anything and everything can change. So things that you look for, you want to know, are your prescriptions still covered? Because what went on this year in the 1-year contract is really completely unrelated to what's going to go on next year. Think of it that way. It's completely different landscape, completely different rules. So are your current prescriptions going to be covered next year? Do you have any new prescriptions that you need to add? Is your selected pharmacy still preferred in network, or did it move to out of network? You won't know unless you look. Are you getting the lowest premium and drug cost possible? Your drugs are your drugs. It doesn't matter where they're coming from, mostly. You just want the best deal that you can get out there, so you're not throwing money, down the drain. But what's changing is everything. The plans that are offered in your zip code, the formulary, are your drugs covered? The pharmacies, are they moving in and out of status? Well, what we're seeing between just literally today, 2025, and for January 2026, the number of plans being offered across the country has been reduced from an average of 14 plans to 10, 11, or 12. So some players are out of the market. They've just up and said, we can't make a profit here, we're done. Cigna sold their Part D plan to HSHC, and they call it now HealthSpring. Completely different plan, might not have your drugs covered. So a lot of changes going on. There's also been a pretty dramatic cut in the number of RXs that are covered, prescriptions that are covered. The share of covered drugs has dropped 19% just since 2010. We don't know how big a drop is going to happen this year. We haven't seen, well, all the formularies are out there now, but because there are thousands of drugs, we won't know until somebody smarter than me does a big analysis. And the pharmacies, again, can switch from in-network to preferred to out-of-network, and so forth. You won't know unless you shop. Now, here's the bigger issue, John. I was telling you about this earlier, excuse me, and Kristen. When you use a broker or an agent, And you should use these really good resources when they're independent, unbiased folks. Um, they get paid a commission, which is how lots of things get sold in this country. Well, prescription drug plans and Medicare Advantage plans and Medigap plans, they're all commission-based products. Well, for 2026, most prescription drug plan insurance companies have stopped paying agents and brokers their commissions. What that means for you is the plans are pulled off of the platform that the brokers use. So if you go meet with your broker and reshop the plan, last year, I think 4 of the 5 major insurers were paying commissions. WellCare was not paying a commission last year, and they're not paying in 2026 either. But they had 4 of the 5 top plans offered on their platform that they could tell you about, and they could shop your drugs with you to make sure you got the best deal amongst the 4 options they had. Well, this year they're down to 1 option, maybe 2. And all of the cheapest premium plans are no longer paying commissions. So, my biggest tip for you this year is you need to shop your own plans. And you need to figure this out before you see your broker so that you can assess whether the plan he or she has to offer is okay. Like, all right, I'm going to pay $10 a month more. That's probably very low. Or I'm going to go on my own and just go to WellCare or to Humana. Those are the 2 lowest paying Part D plans in our New England area this year. So it is not the broker's fault. They have no say in any of this either. It's that the insurance companies have decided to stop paying commissions on Part D plans, except for a
And
couple.
and Marcia, where do you recommend that people go to
Yep,
shop the
that's
plans? The
you're
Plan
going to
Finder
go.
and
I have 2 good places for you to go, but let me just tell you about the plan finder. So your Medicare.gov, not .com, Medicare.gov has the plan finder or the find plans tool. It's relatively easy to use once you've used it once or twice. You load in your drugs, you put in your zip code, and it will kick out the 11 plans that you have as options this year. So Medicare.gov, it's right at the top of the page, find plans for 2026. Thanks, John. Other things to note, the 2026 premiums plus covered drugs have a cap. So most people pay no premium to Medicare for Part D, directly to Medicare. Like we pay our Part B premium, we don't have one for Part D unless you have a Part B IRMAA. And then you'll have a Part D IRMAA as well. It's much smaller than the numbers we looked at earlier. It's more like $25 or $35 for the first tier up to $120. So it's more nuisance than significant dollars, but you still have to budget for it. You will, however, pay these monthly premiums to the private insurer that you choose. There are still some $0 monthly premiums in some states, not all. I'll show you some numbers in a minute. And also note that the covered drugs are capped for the second year, thanks to the Inflation Reduction Act. But instead of $2,000 for 2025, that's your cap on covered drugs this year, it has jumped to $2,100 for 2026. But important, your total cost for Part D can exceed the $2,100. If your drugs are $2,100 by themselves, you still have to pay a monthly premium. You also have situations where your drug is no longer covered by the plan you're in this year. And when the drug is not covered, it is not subject to the cap. And if you have an out-of-network pharmacy, those drugs that if you're using an out-of-network pharmacy, you also are not included in the cap. So you have to be really careful of what to watch for. And I'm going to show you a number of, I think it's pretty shocking stuff. There's a lot of pricing changes for 2026. So Maine and New Hampshire, let's start with you guys. If you have a residence, your zip code is in Maine or New Hampshire, the Part D insurers call those 2 states Northern New England, Northern New England, really? Just those two? Start at the bottom of this table. In 2024, the cheapest premium was 50 cents, and we had 20 plans in these two states. Then in 2025, the cheapest plan was zero, but we only had 14 plans to choose from. And this year, you still have a $0 plan. It's either WellCare or Humana. I can't remember. But it might not be the same $0 plan as 2025, but now there are only 9 plans offered. So the number of plans just in 2 years has been cut in half for y'all in Northern New England. I would have thought, me being in Massachusetts, that I was in Southern New England, but no, we're in Central New England, the other 4 New England states. And you
How
can
is
see what's
Vermont
happening.
in central New
I,
England? It
I
makes no
have
sense
no
to me.
idea, not Northern, I know. Again, I don't know who puts this stuff together, but it's not impressive, I'll tell you. So here you see 2024, we all had a 50-cent premium was our cheapest. It was WellCare. This year, the cheapest premium is $8.40, and it's a Humana plan. So not only do you want to get the least expensive possible scenario premium that you're paying along with your drugs, you have to do the combination. You may have to change plans to get the least expensive plan this year. So it's not WellCare. And we've gone from 20 to 11 plans, so pretty much cut in half in 2 years also. If anyone is in New York, New York stresses me out. I have a lot of clients in New York. They were at $3.70 in 2024, and they're up to $35. This is their cheapest plan. So if you take no drugs and you're 70 years old and you have to have a Part D, this is what the New Yorkers are paying, just right over the border from Western Mass and Vermont, here in central New England. Their plans have also been cut. And you see the highest premium plans are also insanely high. But if you have certain combination of drugs, that might be your only option. So,
Hey, Marcia,
yeah,
a quick question.
sure.
You 2 years ago, we had talked about the 50-cent plans
Mm,
in Massachusetts and New Hampshire. What
yep.
ended up happening with those? Did they increase their premiums the following year? Did they go out of business or stop offering them?
No, great question, John. No, they are still alive and well. They're the number 2 plan. Um, they are, so in 2024 for New Hampshire, it was WellCare, it was 50 cents. 2025 was WellCare, 50 cents. Zero, I mean, they went down. And you still have a $0 plan this year. I just can't remember if it's WellCare or if it's Humana. They're still alive and well, but they're the insurer that stopped paying their brokers commissions for 2025, and they're also not paying in 2026. So they got this huge mass of new clients coming in, and then they move the brokers out of the mix. So you have to be on your own if you want to keep WellCare. It's a crazy thing. For those who have residences in the warmer states, warmer than New England, still lots of $0 options. Well, one, at least in Florida, Arizona, and California. Usually there are 2 in these more retirement common states, but their plans have all been cut in half as well. So we're seeing this real pressure, this compression of Part D plans being offered. It's just interesting around the country. It's all over the map of, are there any $0 or say under $1 plans offered? Sometimes. And are there still a lot of plans? No. Now, let me give you a few examples. I started in Manchester because y'all have a $0 monthly plan. It is WellCare. Oh, here's our answer, John. WellCare is still. So they were 50 cents 2 years ago, zero last year, and there's a zero option this year. Now, your drugs have to work in order to get the $0 plan. But here is a plan that with just 2 generic blood pressure medications, monthly premium is zero, and it's zero. So for those of you who have 1 or 2 or even 5 generics, you might pay nothing in 2026. Oh, that's good news. All right, so I did have some good news. I was thinking I didn't, but there's some good news.
Wonderful.
However,
Thank you.
yeah, you bet. But if your pharmacy is out of network, you're not going to pay zero. So you have to check. So if you wanted to go to the Manchester Metro Treatment Center, wherever that is, you would pay $569. You still have a $0 monthly premium, but you have to pay for the drugs. So don't do that. Check for your pharmacies. This is in the plan finder when you go in to use it. You will pick 5 different pharmacies and you want to make sure that they are preferred or in network. And even if you wanted to go to Ken's pharmacy, again, don't know where it is, they're only in network versus preferred in network. So an in network situation here makes, I mean, it's still not bad, right? $139 for the year, except you could be paying zero. Now, took those exact 2 same drugs, and I came down here to Plymouth, Massachusetts, whopping 2 hours south of where y'all are. We do not have a $0 plan in what were we, central New England this year. The cheapest plan is $16.40 a month, and total drug and premium cost is $196, whether we use a retail pharmacy or mail order. But now I added Eliquis. It's a brand name drug. You see it advertised on TV. Now, Blue Cross Medicare RX Value Plus, PDP is prescription drug plan. The Blue Cross Medicare plan is the cheapest, even though same 2 generics, and all I did was add 1 brand name drug, Eliquis. It's a blood thinner, I think. Now my premiums went from $16, all right, to $20, not a big deal. But yowza, I've got to pay, almost $1,300 total. But again, that's only if I'm in the preferred lane. So if I end up at High Point Pharmacy down here in the Plymouth area, I'd have to pay $9,000 for the drug because my pharmacy is out of network and it is not, it doesn't line up with the $2,100 cap. Whereas CVS is $1,000 and mail order is $1,037. These are the 2 preferreds. Well, actually, mail order is not even preferred. It's just in network. So this is the output you see from the plan finder. And you get these 5, you put in your 5 pharmacies. I always do mail order, CVS, Walgreens. I try to find an out of network so I can see what the damage would be. And then I pick another one. So that's how you get started.
So
But you can see, oh, go
people
ahead.
really have to pay attention to
The
the
pharmacies.
pharmacy. That's what I'm
You
taking away from this. And the preferred
absolutely.
looks
Yep.
like it's the lowest cost in the
Within a few
scenarios that you've
dollars of
shown.
mail order. Mail order
Yeah.
is usually the lowest, but you can see here, and it is here, even though it's in network, it's just more efficient to send things through the mail than for you to go into a pharmacy. But yeah, John, that is exactly the big message. You have to get really granular with these pharmacies. Now, the other piece is that you need to watch to make sure that all of your drugs are covered. So here, it's the exact same, 2 generic blood pressure. Eliquis is still in there. Then I added Lipitor, which is a brand name. Atorvastatin is the generic sister. Lipitor is not covered in this plan. So what that means is if you're in a preferred pharmacy, even though it's preferred, it is not covered on the formulary. Therefore, you have to pay your full retail price. It is not capped at the $2,100. So in a preferred pharmacy, you'd pay $6,800 for 2026. Just the drug cost, you still have to pay the premium. It was $20 or something. But if you're a combination of a drug not covered and you're out of network, now you're really paying through the nose at $15,000. You don't want to do that. And you
So
do
how do you get
literally have to,
Lipitor covered, Marcia?
you don't. In most cases, you don't. You have to talk to your doctor. And that's why this shopping period is really important. If you have something like a Lipitor, the ones that are coming up a lot that are not covered are GLP-1 drugs and a lot of the insulins for anyone dealing with diabetes. So see, I mean, it literally shows in this yellow warning light, right? Not covered. So you call your doctor and talk to the doctor's office and let them know that, hey, your drug is not covered. Now, you can also look through the other plans, right? This is just the one I picked. So it may be that there's a better option in what was this, Blue Cross? I think this was the Blue Cross plan. Yeah. You might find something better with United Healthcare plan or HealthSpring or something. So you do look through all of your options, but assuming it's not covered, call your doctor, and one of two things will happen. Either the doctor will say, well, we can switch you to the generic. That's fine. Or some people can't get the same value, health value using the generic, and they have to be on Lipitor. In that case, your doctor appeals to the insurance company and has to have a whole form they fill out that it's medically necessary for you to be on Lipitor. And then it might be covered. They'll go and fight for you, but it's a long process. So you want to get ahead of that early, like this
Wow.
weekend.
That's
Yeah,
scary if you're not if you're in a drug that isn't going to be covered by that $2,100
exactly. It
cap,
really is.
can
And
be
it
a
can happen
problem.
because it's not on the formulary for this particular plan, or you're in the wrong pharmacy. So check both pieces there. All right, take a little drink of your coffee or your soda, whatever you got, your drink. We're going to talk about Part C plans. A lot of people substitute their Medicare with a Part C plan. And this, again, it's this packaged product offered by private insurance companies. They're in the news a lot. They charge in a completely different way. And you still have to have you have to have Medicare Part B, pay the premium and the IRMAA. But then if you're in an HMO, you very often don't have another monthly premium to pay. In a PPO, preferred provider organization, you might have a premium, or you didn't have a premium in 2025, but you now have one in 2026. A lot of PPOs are now getting appended with premiums if they're even offering them. And in that case, you have a different pricing structure entirely, that you pay a share of everything you're using throughout the whole system. So you pay $25 to see a doctor or $50 to see a specialist, or your days in the hospital are $550 per day for the first 6 days. It's just a completely different pricing schematic because you're expected to use a network. The long and the short of it is the out of pocket can be very, very high, even if you have $0 monthly premium in these Part C plans. In 2026, the Part C maximum that can be charged for an in-network is $9,250 or $13,900 if you go in and out of the network. Why this is important is because this woman, whose name is Kathy, that I'm working with right now, got a cancer diagnosis back in February, and she has a PPO, Medicare Advantage plan. Kathy has already spent over $10,000 for her free Medicare Advantage plan. It's if you get really sick, if you get a cancer diagnosis, if you have some immunocompromised situation and chronic problem that comes up that requires fancy, expensive outpatient drugs, you're going to get hit with these really high costs. Now, it's fine if you have $13,900, sitting over there that you can just write a check for. It's very expensive to be on a Medicare Part C plan when you get sick. Full stop. Now, since it's open enrollment period, you do have an opportunity to reevaluate the Part C plan you're on. Now, you all should have gotten an ANOC, an annual notice of change. It came at the end of September, first week in October. They're really big. Most people don't read them. 30 to 40 pages. It shows you in a table what this plan charged in 2025 and what it's going to charge in 2026. You need to review the ANOC because you're looking for a whole lot of things in addition to just your Part C, your Part D drugs. The same stuff that everyone who has a standalone plan has to reshop for, so do you. Are your prescriptions still covered? Are your new prescriptions covered? Is the pharmacy in network? Are you getting the lowest possible combination with the Medicare Part C plan that you currently have? You have to get the answers to those questions. Furthermore, you have 4 more steps to cover with a Medicare Advantage plan this time of year. Are the providers, are your doctors in the network anymore? With my new client, Kathy, Her two oncologists were no longer accepting her PPO. They weren't accepting anything from United Healthcare, it turns out. So she has to talk to them about what are they allowing for 2026, because you can't change her physicians. This is cancer treatment, for heaven's sake. So she's got to find a new plan. Can you really afford the out of pocket? Like, really look at your budget and your numbers. And another way to look at it is this where you want to spend your first $13,900 if you get sick in 2026? I don't know. That's probably not where I want to spend my first $13,000. Maybe it's just me. Then you want to look and see how your copays have changed. How many hospital days do I have to pay for up front, and did the rate increase? The answer is yes and yes on both of those, by the way. Most plans that I've seen already this year, they went from like 5 days that you have to pay up front to 7, and the cost went from give or take $350 to $500. Everything can change in these 1-year contract plans. You chose them, you have to reshop them. That's sort of the commitment that you make. Have my copays to see the doctors and specialists increased, or maybe they've decreased? Probably not. Are they still in network? Have the prescription drug copays changed? They are in tiers. Are you paying more? Did a drug that you thought was a tier 1 move to a tier 3 and you're paying more? Do I now have a monthly premium for the medical insurance side or the prescription side? They can have two different premiums. And then have there been changes to the extras? A lot of people like these Medicare Advantage plans because they have extra goodies, as I call them. What's different though? Did your dental plan get canceled? Is your dentist even still in the network? Are you still getting some coverage for vision and glasses, and did it change? Did the hearing aids, can I still get them? What about my grocery card or my gym membership? All this, because they're extra goodies, we're all up for change in 2026 as the insurers got squeezed on their margins and their profits.
Hey, Marcia, what percentage of Advantage plans have prescription drug benefits?
Almost all of them, and
All
you
of them.
have
Okay.
to have them. If you don't have a special needs plan, you have to get your Part C with a Part D, or you don't have any prescription drug coverage. So it's almost everyone signs up for the combo Part C, Part D.
Okay, thanks.
Sure. Now, starting this calendar year, 2025, lots of Part C plans started to close up shop. Now, last year, this time, we knew that about 1 million seniors were left out in the cold across the country. And what we saw were these huge players, Humana, Cigna, CVS, Aetna, were all pulling back in different ways with their Part C plans. Either they just shut them down entirely for certain counties, or they would shut down their 2 of their 3 PPOs. They really started to bring in their network and make it more limited so that they could be more profitable. Vermont had a different situation. So last year, Vermont is considered a small market. So in Vermont, this company called MVP Healthcare and the University of Vermont Health shuttered their joint Medicare Advantage plan. They'd been offering a joint plan through University of Vermont, and they shut it down last year. This year, things are all over the map. And I'm not 100% sure that I'm 100% right on this chart, because I am trying. Every time I turn around, there's something new being announced. So things like WellCare. So what I looked at was who's cut commissions on Part D plans, who discontinued Part D plans, who cut commissions to the brokers and agents on Part C plans, who discontinued some PPOs, and how many seniors are impacted if I could find the number. So what you see down the column on the far left, well, no particular order, WellCare, Aetna, Blue Cross, Cigna, which is now some of it owned by HCSC, Humana, United Healthcare, Elevance, Anthem, Mutual of Omaha. What is that? 8 or 9 major insurance companies. Lots of them cut commissions on Part D. Some of them got rid of all of their Part D plans entirely. This is in the Midwest mostly, this Elevance and Mutual of Omaha. Cigna sold theirs off entirely. In the Part C, lots of these major players are cutting commissions, but only in some markets. But you won't know if it's your market unless your broker tells you. They've discontinued PPOs. And again, we have millions of seniors impacted by this. And what I want you to imagine, I mean, I can't see any of you. All I can see are my slides, and then I can see John when I shut the slides down. I have no idea how old you are, but imagine yourself at 80 or 85. My parents are 85 and 86 this year, 86 and 87. They can't do this. They're pretty healthy. My mom, sharp as a tack. She gets it wrong every year. I mean, this is so complex. And then you go for help, and then maybe your broker can't help you because he can't get paid, which means the plan is not on his platform. Let me bring it closer to home. Vermont. What in God's name? So the very first day of open enrollment, the 15th, I get this hysterical text from a friend of mine here whose family happens to be in Vermont. And she says, "Oh my God, Marcia, all the Medicare Advantage plans have been shut down in Vermont." I thought, well, that can't be true. So I hop online and I go look at Vermont. What in God's name is happening? We knew MVP Health and University of Vermont shut last year. So I knew that. Oh, she was right. Blue Cross and United Healthcare did not review their Medicare Advantage prescription drug plans for 2026. That's where everyone was, except a few thousand people were in Humana's Medicare Part C plan. So Humana is still operating in Vermont, but only in a few of the counties. So that left something like 25 or 45,000 Vermonters with no plan that they have to reshop right now. I bring this up because, yeah, it didn't happen in Massachusetts, right? It didn't happen much in New Hampshire, but this is what's coming. This is what the canary in the coal mine. The companies are trying desperately to keep their profits up and their revenues up, which means they have to cut what is determined to be unprofitable areas. Apparently, the entire state of Vermont didn't make the cut this year. There are other players also. We've got UCare in Minnesota that was affiliated with the University of Minnesota, Centara in Virginia, Samaritan Health in Oregon, also Moda Health in Oregon. Oregon apparently is the next state to fall. At Care and Care in Texas. Everyone in those plans did get a notice, but again, they probably didn't read it. So I worry about that kind of thing. These are seniors. These are people dealing with cancer or taking care of a spouse who is literally dying. This is not what old people need to be dealing with this time of year. And yet this is where we're at.
So Marcia, if they get their Medicare Advantage plan canceled and there's no other options, what are they to
There's,
do? To
there's
go on
always
to
another option. You cannot be in a complete healthcare desert. So this is what you do.
okay.
Thanks, John. You read your ANOC first and foremost. In some, but very few cases, people will be automatically moved to a new Medicare Advantage plan at the same insurer. They will tell you. Most of the time, they tell you, like this little notice here that says, therefore, this website will go offline on January 1st, 2026, after the 2025 plan run out period has ended. Like, you're on your own, people. Assume you're on your own. So you have to proactively find a new plan and enroll during the OEP right now. You will also have a special enrollment period, SEPA special enrollment period, from 12/8 to the end of February. Because some people aren't going to figure this out until they show up at the doctor's office in January or they try to fill a drug. The plan's been canceled. And if that has been the case and you did not take action, you will be in original Medicare A and B. So you still have hospitalization coverage, you still have doctor coverage, but you don't have the equivalent of the Medigap now. So you would be on the hook for that 20%, and you don't have a Part D plan. Now, if you're on one generic drug, it's like, oh, suck it up. You'll go figure it out, right? Most people aren't on just one little generic drug. So they're going to find out in January they don't have any drug coverage, which just you can tell by my passion here. I'm so angry about all of this. But where's the good news in this? Now you're eligible to join a Medigap plan with no underwriting. So before you usually can't join a Medigap plan midway through your retirement. You either did it at the beginning or you're out of luck. But this opens up the door for you to get a Medigap plan, and you'll be able to choose a standalone Part D plan. You can also pick another Part C plan if it's being offered in your area. But you got to do the work. I mean, there's really no way around this, and it's pretty unsavory for lots and lots of people.
Are the insurers leaving the Medigap market as well?
No, they're not.
Okay, so that's good news.
Yeah. We'll see for next year. I mean, there's just a whole year in front of us to see what shenanigans are going to be played. But yeah, all right. So I'm sorry I don't have better news for you, but I'm an action kind of girl. So let's do some action steps here. The most important thing you can do is something. Do something this open enrollment period. I find it's too squishy to go, oh, you have from October 15th to December 7th. So for all my clients, they get an email that says November 1st is your day. Just put it on the calendar. You gave out candy yesterday. Now it's November 1st, and you still have 3 weeks before Thanksgiving. So November 1st is your day to reshop your plans. Learn how to use the plan finder on Medicare.gov. Whether you are a Part C plan or just a standalone Part D plan. So you need to do the shopping. And what I will say is sometimes people would reshop and then change their mind. That's fine. You still have until December 7th. It's the last choice you make on December 7th that is your lock for January 1st. So maybe you went with WellCare or didn't reshop, forgot to. You still have until December 7th, and you can then change to Humana or whatever your scenario is. This is a timeline that I put together for folks. I mean, in October, you can start poking around. Of course, we got just a few days left of October, but it's November 1st. Use the plan finder, set up your My Medicare account. If you haven't, you just need your Medicare card and put that number in. You can load your drugs in there and reshop from behind the login to see what your choices are. If you have a Part C plan, you do need to go out to that insurer's website. So if it's United Healthcare, you go to the UHC site. If it's Blue Cross, you go to Blue Cross site, whatnot. And then take a look at your options and literally on November 1st, same day, reshop that plan and apply. So you can call the insurance company if you're making a change, or you can enroll online. You don't discontinue your current plan. You just let that ride out. It shuts down on 12/31 automatically. And so whatever you have in the system goes into effect on January 1st. Some people aren't changing their plan. So let me say that too. I talked with another client early on, and she has WellCare, and WellCare is more expensive this year, like by $8 or something. And she said, do I have to change? Can I just pay the $8 a month and go on my merry way? Absolutely. No harm, no foul. But she knows, like she made that decision. She has the cash to pay. It's only a little extra in her budget. So you don't have to switch, but you want to just be informed and knowledgeable so that you're not finding yourself in an out-of-network pharmacy or a drug that's now uncovered. All right, in early December, you get your determination letter. Take a look at all of that and decide if you need to appeal IRMAA. And then January 1st, like magic, you're going to have your new plan in place. What changes can you make during OEP? You can switch from one Part D plan to another, like we've been talking about. It can be at the same insurer or a different insurer. So you can go from WellCare to Humana, Humana to WellCare, et cetera. You can also change your Part C plans from one insurance company to another, or from one type of Part C plan to another. You can go from a PPO to an HMO, or an HMO to a PPO. You can, switch and swap as needed. You can also go from original Medicare with a Medigap to a Part C plan if you want to go that direction. What you cannot do is go from a Part C Medicare Advantage plan to original Medicare and buy that Medigap that you need to fill in your share of the costs. In every case, you would need medical underwriting unless you live in Massachusetts, New York, Maine, or Connecticut. Or unless your Medicare Advantage plan was canceled on you for 2026. So when the insurance company sort of does damage to you and to your health insurance, then you can get into a Medigap with no medical underwriting. There are also some states that have these birthday rules, and they allow you to switch. If you already have a Medigap, you can switch from one Medigap to another of equal or lesser value, but it's kind of outside OEP. It's around your 65th, or is around your birthday month. So if you have a Medigap that you need to switch, we could do some research on the state. I don't remember. Illinois has a birthday rule. California has one. There are a handful of states that have them. But mostly what you want to remember when you enter Medicare, you either chose the quartet or you chose the trio. You're making a 30-year decision. It's very, very hard, except in these 4 states, to go from the trio, Medicare Advantage, back to Medicare and get that Medigap plan. You haven't been paying your premiums all along the way. So the time people want to get into Medigap is when they're older and sicker, and the insurance companies want you leased at that particular time. All right, resources. And I was mentioning to John, I will put a lot of this stuff on a tour. I think it's a 3-pager. You'll have resources, you'll have links, you'll have the latest pricing and such as soon as I get it. So it'll be a few weeks yet, but I'll send it to John and he'll have it available so that you'll have something you can use and not have to remember all this stuff. You research, here's on the right, this is what the homepage to Medicare.gov looks like. The nice little man with the little windy road. It's open enrollment now. So you find plans now and that's where you shop your plans. On the left, explore your Medicare coverage options. This is what you'll see once you click on find plans. You put in your zip code over on the bottom. I don't know if you can see my mouse here. You continue without logging in. So if you don't have an account, you put in your zip code and it's for 2026 and continue, and then you load in your drugs. If you have a Medicare, even Part A, you can log in, you can create an account and load in your data there, your drugs. The other option I want to mention, this is a for pay option. There is a company out in Wisconsin that I've followed for a long time, and they have a new, much fancier database, which is the Plan Finder, just put in a way that we can all actually understand it easier. It's called HeyMo, and Mo stands for Medicare Open Enrollment. It's heymo.com. You're welcome to look at it. It's $30 a year to be a subscriber, and they do all the work. Once you load in your drugs, they will proactively send you your results. They do things like they look at 20 pharmacies instead of only 5. So they'll help you find the best pharmacy in your area for the coming year. They'll look to see if a brand drug is not covered. They'll look for the generic alternative to see if it's covered. Sometimes it's the other way. Sometimes the generic, I see this with the insulin products. A generic insulin is not covered on, I don't know, Blue Cross's plan, but the brand is. No, I don't know why. It just is. So I find this little app or program to be immensely helpful. And if you want to try it this year, Melinda was nice enough to give me a special code, which is Marcia, my name, MARCIA, all caps, just Marcia. Put that in the coupon code, you get $5 off. So it might be worth to give it a try. If you hate it, then use the Plan Finder again. Try to get an appointment with your SHIP organization, usually offered in our area through the Councils on Aging. So in Massachusetts, we have Shine reps. In New Hampshire, SHIP is SHIP. And if you're in Florida, their SHIP is Shine, but it means something a little different. And these are the free resourced volunteers who can help you sort through your drug and your Part C situation, or help you with your parents if they're in another state. Oh, Lord have mercy. Now, if you're just joining Medicare, you do sign up for Medicare on Social Security's website. And Social Security just rolled out a new web page the other day, a new home front page, and they took Medicare off the homepage. Now, it is way up here that nobody sees. It used to be in apply for benefits, it would say apply for Social Security benefits, Medicare benefits, or SSI, or disability. Now it just says, I can't read what it says, but it does not have Medicare anymore. I think it says retirement or disability or other stuff. Well, when you click on apply for benefits, it's over on the right, apply for Social Security benefits. Like, oh, I thought I was supposed to do Medicare here. Well, you have to scroll all the way down to the bottom and find the little teeny tiny link that whispers, apply for Medicare. And then it will take you where you need to apply. Super annoying. I emailed them yesterday. Hopefully they'll come to their senses. And the last thing I want to say is please keep reading. Watch stuff online. This is me doing a Yahoo Finance webcast with Bob Powell a couple of weeks ago. He did a whole series on Medicare Open Enrollment on Yahoo Finance called Decoding Retirement. So I got to do a couple of episodes with Bob. My Boomer Retirement Briefs blog is free to everyone. I just put content out there so you can see what's going on. And read any really good resource. Will keep you updated. And that's what I have this year, John. It is fraught
Awesome.
with peril.
We got a bunch of questions.
All right, I'm here for you.
All right. Can you go to slide 32 where you were showing what plans were coming and going?
Mhm.
And the question was, does yes mean leaving and no mean staying in terms
Oh,
of what?
in with the discontinued
Yeah.
PPOs? Yeah, so yes means, so it should be really phrased in the form of a question. Did this company discontinue some of its PPOs? Yes, Aetna did in some markets. Humana did in some markets. United Healthcare cut 109 of their PPOs out, and Elevance and Anthem did some.
All right,
Yes.
great. Next question. Do seniors in assisted living or nursing homes have to use the pharmacy that the facility prefers?
That
They said
the
usually out of
facility
network.
requires. It's not a preference, it's a requirement. Yes, they do.
Okay.
They can also, but if there's a question, they should talk to an advocate. There's usually some specific advocates in these nursing homes or assisted living facilities that help the residents with their drug costs. And particularly if it's too expensive for someone, and this usually happens once they're on Medicaid, you can get lots of extra help from whatever state you're in. And these advocates or these social workers will help sort through the options for each individual.
Okay. Thank you. Next question. I thought insulin drugs were supposed to be capped at $35 a month across the board. Why are so many not covered in 2026? Is there a way to get them for $35 a month?
Yes, yes, and no. Yes, insulin drugs are capped at $35. However, there's a word missing. Covered insulin is capped at $35 per month. So is the exact drug, and I never knew this before, they're like 50 different insulins. They do different things. They're manufactured by different manufacturers, pharmaceuticals, and the Part D plan gets to decide. Now, all plans have to cover insulin, but not all plans are required to cover all the insulin. So they'll pick three, one short term, immediate action, one longer term, and one extended, right? So that they've covered their insulin, but only three of the possible 50. So yeah, you have to shop really hard for these drugs that are to make sure you're getting a plan where the insulin is covered. But unless the drug is covered on the formulary, it is not subject to the $35 cap.
Wow. Okay.
Yeah,
I didn't know. Complicated answer, but
I know.
good to know. What does having medical underwriting mean?
Medical underwriting is a process by which an insurance company checks your medical history, usually for the last 5 years, to see how healthy you've been or not. So what drugs do you take today? What surgeries have you had? Have you seen a cardiologist? Have you been in an accident? Have you had cancer? And they determine, once they poke through all of your most personal health background, whether they want to insure you or not. If they decide yes, they can charge you more per month than someone who came in at the beginning of retirement. They can make you wait. So if you're a cancer patient, they can make you wait 6 months before they'll cover the treatments you're getting, or they just outright deny you. So if you're going to switch, you better be really healthy, because they're going to deny you.
Gotcha. Okay. That makes sense. And
Except, again, in Massachusetts, Maine, Connecticut, New York, because we all pay higher monthly premiums overall for our Medigaps, people do come and go. And I literally had someone, how old was he? 85, I want to say. Um, and been in a Medicare Advantage plan, and he switched over to a Medigap. No underwriting in those 4 states, in only those 4 states.
certainly an advantage to living in Massachusetts. All
Well,
right.
some people would say yes.
What do you suggest for someone who does not take any prescription drugs? What should they shop for in Part D?
Yeah, the cheapest monthly premium. If you're in New Hampshire, you get a 0 monthly premium. I forget what I told you it was in Massachusetts, but like $16. That one really burns my butt, I gotta say. If you don't get into your Part D right when you're entering Medicare, you will be assessed a 1% per month late fee when you do need a drug 20 years later. Whatever, I should have done easier math. 5 years later, that's a 60% permanent penalty for the rest of your retirement on what's called the base premium. The base premium is about $35 this year. So, if you skip a year or two, it's not going to be a huge hole in your pocket, but people are really mad that they've been assessed a penalty for the rest of their retirement from 70 to 99. Um, so I just can't advise or suggest or encourage you to skip joining a Part D plan. That's why New York stresses me out to no end, because their cheapest plan is $35. If you take nothing, you're literally throwing money out the window. $35 a month.
Yeah, it's
So you,
brutal, but you have to do
yeah,
it because you have to avoid that penalty.
yeah, because you don't know when you're going to have your heart attack and you need Brilinta, and it's super expensive. And then you'd have a big penalty on top of
Right.
the expensive drug, but you can only get into Part D at this time of year. So if you had a heart attack in February and you need this, a blood thinner, Brilinta is one of the ones I look at a lot. It's really expensive. You have to pay full freight for the whole rest of the year until you can get into Part D at the end of next year. And so you're out thousands of dollars, all because you didn't think you were going to be the one who had a heart attack or any other
Yeah,
ailment.
you don't want to get into
Yeah,
that situation.
you really don't.
All right, next question. How does one find a reputable insurance broker besides Shine? If you have a financial advisor, I know that clients of Milestone Financial Planning and Cornerstone Financial Planning are both on this webinar today. Reach out to your advisor. I know both firms have good relationships with brokers throughout New England and beyond.
Yeah.
Marcia, besides that, what advice do you have?
It's kind of the same for me. You might want to shop around if you're not calling your Milestone or Cornerstone advisors. Um, there are some big names out there right now. There's an organization called Chapter here in Massachusetts. There's Boomer Benefits in Texas. Uh, I have one guy that I like and refer to. I've found it extremely difficult to find an independent, unbiased broker. Not because of them, but because again, they're limited to their platform. So if you're going to use a broker, I would still shop in advance so you can see your range of Part D plans that are offered in your zip code. So you can have a much more intelligent conversation with the broker and then decide if you're willing to pay more for the one or two plans he has on his platform.
Yeah, good advice. Going on to Medicare.gov and doing that
Yeah.
plan finder research ahead of time keeps you more informed.
Really does.
Next question. Any advice for a young disabled adult with Medicare and Medicaid who's currently on an Advantage plan, which is being discontinued?
I'm going to pass on that question. So no, I don't have any good advice.
Okay.
Disability is if you think Medicare for us older people is hard, it's 100 times harder when you are someone with a disability. I'm sorry, I can't be helpful there.
All right. What kind of impact are Wegovy and the other similar drugs having on the Medicare cost increases?
It's an interesting dilemma. Most of the GLP-1s are not being covered by Medicare. Some plans decided to cover them, but I think overall, because there are some of these drugs that are really high cure or high preventive, like preventing the bigger high cost items later. If you're on these weight loss drugs or the diabetes drugs, apparently they're really helping with cardiovascular risk decreases and that sort of thing. So the whole industry is in an upheaval as to sort of what to make of this. It's that age-old problem, that sort of concern in the health insurance industry that's always been, oh my God, what if we find a cure for cancer? Then we're not going to have all the treatments, and then where's the revenue come from? So it's just that we're in a really interesting time. And there's a lot moving. Congress is kind of paying attention at this point. These middlemen, the pharmacy benefits managers that have been jacking up costs, particularly on employer plans for decades, they've been called on the carpet. So there's just a lot of change everywhere, from new drug improvements to process to sales, that then impacts, of course, revenue and bottom line. So we're just in a period of upheaval.
Yeah, change is happening.
Yeah.
What can someone do if you mentioned the ANOC a couple times, the
Mm.
annual notice of change? What if somebody threw that out or disregarded the email? How do you get a second copy of that?
You can call your current plan. So if you have a United Healthcare plan, just call United Healthcare, or they're online. So you just go to, they're a little hard to find, but you can dig through whatever insurance company you're dealing with today that has your 2025 plan, go to their website, and the ANOC is in there buried somewhere. Every company is different. I just have to go hunt and peck until I find it.
Okay. And do you think
Probably quicker to
the
call.
the government shutdown is going to affect the open enrollment period at
No,
all?
no. It didn't directly affect Medicare. So from a Medicare perspective, we have what we have. The one thing it's doing a little bit delaying Part B premiums in the brackets for IRMAA, but it is affecting tremendously the ACA. So if you are not yet in Medicare, or your spouse or partner is not yet Medicare age, and you're trying to deal with the ACA, that's where we're all, well, freaking out would probably be the phrase my kids would use. It is a gravely concerning time on the ACA. If you are a little bit higher income people, if you're low income, 150% of the federal poverty level, 200% of the federal poverty level, your information is clear as mud right now, but it's going to be clear on November 1st, and you'll know what your premiums are and what your advanced premium tax credit is. But if you're a higher income person, between like that 300 and 400% of federal poverty level, whether you're going to get any advanced premium tax credits at all next year is greatly up in the air. And that I see a delay, because right now, as of November 1st, the coding is locked, and it's that the the higher income folks are going to be booted out of getting any benefits on the ACA. However, depending what happens with the outcome of the government shutdown, could there be a change? And by change, I mean extending the current law so that more people get ACA advanced premium tax credits. That could happen. I just don't know how it would be operationalized within the systems timely. So really, we're completely up in the air on the ACA. Medicare's pretty locked.
Yeah, hopefully all the Medicare employees get paid once this
Well, remember,
shutdown
Medicare,
is over.
yeah, it's the Social Security Administration that administers Medicare stuff. So your premiums will be calculated by Medicare, by Social Security, and you get that in your determination letter coming in December. That's still right now on schedule. Um, and the COLA was just announced on Friday for Social Security. That's step one. We needed to know Social Security's COLA because people's checks get cut in early January for the January payments. So that's all moving, but the checks can't get cut if we don't know the Part B premium. So they're really locked. I don't see any more than a week or two delay kind of thing, but that's moving.
I seem to remember pre-COVID, I don't know, 18, 19, there was this instance where the Medicare premiums increased faster than Social Security monthly benefit payments, and there's some sort of hold harmless
Yes.
provision where people
Yeah.
getting Social Security couldn't have their premium, the Medicare costs increased by more than the Social
Right.
Security
So
increase.
exactly. So yeah, there is this hold harmless provision. I just have to do quick math. What did I say? 206 minus 185. All right. So the Medicare premium may be going up $21, but the COLA for Social Security on average is increasing people's benefits $56. Higher income folks get more. So there probably will not be a hold harmless provision that
So
your
it's a dollar
$21,
amount,
it's
not a
dollar amount, not
okay.
percentage. Right.
Well, that's too bad.
Yeah, I know. So I have to tell you, that was really hellish for those of us dealing with clients with Social Security and Medicare, trying to figure out the hold harmless and who was getting paid what. And then we had all these tiers of premiums because once you're held harmless, you don't then jump, another year. Say you were held harmless at 185 and everyone else is at 206. Well, then the next year you can't jump the 185 people to 206. Then they went to 185 to 195, but the 206 people went to 222. It's just
Wow.
nightmarish, but we could deal with it if we had to.
All right. Well, we got to the end of the questions, a little bit over time here,
Oh,
but this is great information. Um, Thank you again. I hope everyone got a great deal out of this. My main takeaway is you have to do some research this year. Don't just assume that your Part D plan is going to be the best for you next year as it is this year, and those on Advantage should absolutely be looking at their ANOX, making sure their coverage is going to continue, and if not, getting with the plan finder, or broker, or some other resource to see
yep.
what's available for them for next year.
Yep. And then just the last thing I'd add to that is spot on is rework your costs for Part B, even though we don't know for sure it's 206, assume it's 206.
Yeah,
And
assume
and then
everything's going up.
everything's going up. And for the next 10 years, Part B premiums are projected to increase about 7% per year. So the retirement income plans really need to be adjusted to accommodate a much higher increase in costs than we were planning even earlier this year.
Is that coming from the trustee report?
It
Yeah.
is.
Wow.
Yeah.
7%. Okay.
Yeah. Okay.
All right.
That's
Thank you,
me. Full
Marcia.
of good news. John, thank you for inviting me.
Thank you to all attendees. Great questions,
Yeah.
great interactions, and we'll be putting this on our website if you want to review it, if you missed anything. And Marcia promised to send her resource once it is all updated, and we'll forward that to everyone that attended today. Thank you, Marcia.
Thanks so much, John. Good luck, everybody.
All right. Bye-bye.